International Pediatrics AIDS Initiative. She also cares as a pediatric hospitalist at Texas Children's Hospital. Dr. Hack has more than a decade of global health experience, spanning both clinical care and public health, including has lived and worked in Uganda for 6 years. She is a passionate, skilled leader, respected collaborator, clinician educator, and a child health advocate who is dedicated to promoting the health of children near and far. Welcome, Dr. Heather Hawk.
Thank you. Good morning. It's wonderful to be here with all of you today. I'm going to share my slides in just a minute, but I would love to know, maybe if you want to just write in the chat, I'm curious, are any of you in healthcare or what industry you work in, just so I can know the audience a little bit. And as you do that, I'm going to start sharing my screen. Okay, so hopefully you all can see my screen now. And I see we've got an aspiring physician in the audience, a pharmacy grad, social services. Wonderful. Oh, it says screen sharing. There we go. Higher education, work in healthcare and an HR capacity, oil and gas. Wonderful. So we've got a diverse audience today. Well, I am so delighted that you've chosen to spend your Saturday morning with me, hearing about pediatric HIV and the work that we're doing through Texas Children's to address this. I also see environmental and school counselor. Wonderful. Thank you, Ruthie, for the invitation and for the warm introduction. Today I'm going to be talking about a subset of the population of people living with HIV that we don't talk about too often, and that is children living with HIV around the world. I hope to share a little bit about my story, about how I got involved in this line of work, and also to share about the work that Texas Children's is doing to address pediatric HIV globally and some of our success stories. So thank you so much for having me. I put my contact information up here and I'll share it again at the end in case anybody would like to get in touch. You can also follow me and our organization on Twitter. So I'm very lucky to work for the Texas Children's Global Health Network. And in addition to being one of the largest children's hospitals in the world, Texas Children's also has a large commitment to global health and helping children and families around the world to have equitable and healthy futures. Before I tell you about the Texas Children's Global Health story, I'd love to tell you just a little bit about myself and my background. I am a physician and happen to be a second generation global health physician. My mother, who's the woman on the far right, did global health work as a family doctor throughout the 1980s and 1990s when I was growing up. And although I'm from Wisconsin, I accompanied my mother on lots of trips around the globe, including living in Uganda as a child. I then went back to Uganda after I finished my undergraduate studies and graduate studies in public health. And I worked on a variety of public health programs in rural Uganda for a number of years, including water and sanitation projects, family planning, The woman on the bottom left is a community health worker who we trained to give Depo-Provera for family planning and malaria prevention. The two photos on the right, on the top is a tree that we often had health education programming under, and on the bottom right is one of our community health workers who distributed bed nets around the community. I also used to run a nonprofit organization in Uganda where we sent disadvantaged young women to higher education. And over the course of a decade, we sent around 200 young women to higher education, either vocational training, university, or graduate studies. So that's me with some of the beneficiaries of that program, and that the little girl is my daughter. Later in my career, I was privileged to work with the BPI, which is the Baylor International Pediatric AIDS Initiative, and Texas Children's Global Health in a number of capacities. I worked in our HIV clinic in Uganda, providing care for children living with HIV for a year in 2016. And the photo on the top left is a banana leaf fiber artwork from one of my patients. And on the bottom is another drawing from one of my patients in the clinic in Uganda. And then the other photos are me with some of the staff there. So I just like to give you that as a little bit of background from where I came into this. And so now, as Ruthie mentioned, I work at Texas Children's Hospital in the Medical Center. And I'm both a pediatric hospitalist, so I care for children admitted to the hospital with anything from pneumonia, asthma, COVID-19, or all different sorts of reasons. But I also work with our global health program, and I'm based here in Houston and periodically visit our sites across the globe. Before I get started, I also wanted to just share my Prairie View connection. And in addition to having many friends and colleagues who are graduates of Prairie View, my special connection is that my daughter also dances at Prairie View every year in the homecoming parade. So we've been there now 4 or 5 years for homecoming. I think we missed in 2020 due to the pandemic. But every other year, her dance team is there. And what a beautiful campus, and what great energy over homecoming. I've really enjoyed the times that I've gotten to visit the campus. So let me tell you a little bit more about BPI and Texas Children's Global Health. We have 11 foundations and 9 clinical centers of excellence, which are pediatric HIV centers in 8 countries across the globe. So most of our HIV programming is in sub-Saharan Africa. And we also have some presence in Eastern Europe, in Romania, which I'm going to share with you, and Latin America, where we're doing more general child health programming. We started as a pediatric HIV program in the 1990s, and over the past 20 plus years, we've grown to address so many more aspects, not only pediatric HIV, but also general child survival, maternal newborn health, malnutrition, tuberculosis, oncology and hematology, including sickle cell disease, cardiology, surgery, and acute care. And we do all of this through a health system strengthening, capacity building, and technical assistance approach. But this is really our why. This is why we do the work that we do in global health through Texas Children's. So the boy sitting here on the table is one of the patients who came to our pediatric HIV clinic in Lesotho, which is a small country that's totally surrounded by South Africa and Southern Africa. He was recently diagnosed with HIV, And believe it or not, he looks like he's much younger, but he's actually 6 years old in this picture. And you can see that he is malnourished, and he's got some stunting, which is low height for age related to chronic malnutrition, and wasting. You see kind of all of his ribs exposed, and he looks sickly. So he came to our clinic in Lesotho, newly diagnosed with HIV, sick, malnourished. And after about 6 months of treatment with antiretroviral therapy, this is the same child. So you can see he looks happy, he's put on weight, and he looks healthy. And this is why we do the work that we do. So across all of our pediatric HIV clinics in 6 countries in sub-Saharan Africa, this is what we do on a daily basis. It's starting children with HIV on this life-sustaining antiretroviral therapy and maintaining them on it over a lifetime so that they can really thrive and reach their full potential. So we'll circle back to his story at the end of the talk. But I think this is really important to anchor the talk and put a face to why we do the work that we do. So let's look a little bit at pediatric HIV and HIV burden in general across the globe. So this first screen grab is from the year 2000, and it shows where the highest burdens of HIV were in the world. You can see most of the burden was in sub-Saharan Africa at that time. On the right, this is now in 2019, so just a couple of years ago. You can see a little bit less of that dark red, but still a lot of HIV burden concentrated in Southern and Eastern Africa. And much of the rest of the world is the light yellow color, indicating low disease burden. Then if we look at the share of children under 5 with HIV, again, rewinding back to the year 2000, you can see much of sub-Saharan Africa is that dark blue color, indicating a high prevalence amongst children. And now in the year 2019, you can see we've made a lot of progress in reducing the pediatric HIV burden in sub-Saharan Africa, but still a lot of work to do. In the 1990s, early 2000s, antiretroviral therapy, or ARVs for short, were introduced first in the US and really changed the face of HIV from a death sentence to a disease that was a chronic, manageable disease. This medication was accessible to people living with HIV in the United States starting in the 1990s. But it was not accessible to people in sub-Saharan Africa at that time. Yet you saw from the previous maps that sub-Saharan Africa had the highest burden of disease. There was a lot of concern from individuals that, it's too difficult to introduce antiretroviral therapy to Africa. Stereotypes that Africans can't keep time, so they won't be able to keep track of taking a multiple doses a day drug regimen for life. Concerns that if we introduce antiretroviral therapy and then we're not able to sustain the programming, that we're setting those people up for failure. So in the early 2000s, which is this screen grab, this shows the percentage of people living with HIV who are receiving antiretroviral therapy. And you can see that Africa, which had the highest disease burden, had essentially 0% of the population receiving ARVs. By 2010, we'd made some progress. And, the US is white in these photos, but that's just because there's no data. It wasn't the focus of these maps. And by 2017, even more progress on getting more people on this life-sustaining therapy. And thanks to the advent of antiretroviral therapy, we've averted a large number of deaths over the course of a few decades now. So you can see the difference between the red graph and the blue graph shows the number of deaths that were averted um, thanks to this new therapy. So we're talking, on the order of millions of deaths averted. And another really important piece of thinking about children with HIV, especially in Africa, the main mode of transmission has been maternal to child transmission of HIV. But the good news is that when women take antiretroviral therapy during pregnancy and breastfeeding, we're able to almost eliminate the risk of transmission. Um, so if we do nothing, if there's a woman living with HIV, her chance of passing the virus on to her baby is 15 to 45% through pregnancy and breastfeeding. Now, with breastfeeding in the US for pregnant women and mothers living with HIV, we recommend that they do not breastfeed because we have um, easy access to formula here. In some other countries where formula is not accessible or clean water supply to mix with formula is not accessible, women do continue to breastfeed even if they're HIV positive. But we can still do things to decrease that risk because HIV can be transmitted through breast milk. But the amazing news is that with intervention, we can reduce that risk to less than 2%. And so we have the tools to eliminate the transmission of HIV from mothers to children. And this is extremely important and has been a big part of our success. So that's a little bit of just background information to set the stage and kind of paint the picture of what HIV has been like globally. And now I want to tell you more about the story of BPI and Texas Children's Global Health. So our work actually started in Romania in the 1990s, where they were having an HIV crisis there. Their outbreak was mainly related to blood transfusions. And between 1986 and 1991, there were at least 10,000 children in Romania who had contracted HIV. And most of these kids at that time were institutionalized. So they were sent away from their families and just put in institutions and not receiving a lot of loving care. And this had a lot of long-term effects on their development. And so at the invitation of the Ministry of Health, Dr. Prairie, who was one of my previous bosses, an infectious disease doctor, was invited to come to Romania and see if he could do something to help address the crisis of children living with HIV in Romania. And in 1996, he started a clinic to treat children living with HIV. And that clinic is still up and running, over 20 years later with great success. At the time in the 1990s, the priority interventions were just survival and less suffering, and also helping to socially integrate these children and helping them access schools and building skills within families and communities to be supportive to these children. So some pretty basic goals at the beginning. But over the last 20 years, we've had remarkable success. So almost half of the children enrolled in 1996 are still alive without intervention. Most of them probably would have died, unfortunately. And we've been able to provide long-term psychosocial support. And more than 70% of those children who are now adults are happy with the quality of their lives and or very satisfied with it. And this cohort of children who've grown into adulthood have now given birth to 212 children who were born HIV free. But Romania was just the beginning of our story. After that, Dr. Klein noticed, this stark inequity in access to HIV care and treatment in sub-Saharan Africa, despite that being the location with the highest burden of disease. And so in 2003, he opened a pediatric HIV Center of Excellence in Botswana. And in the early 2000s, proceeded to expand to 5 other countries in sub-Saharan Africa. And so these are some photos of the clinic in Malawi. It was originally just held in a little trailer that you can see on the top right there. And an interesting story about this trailer is when they set up shop there, HIV is a highly stigmatized disease around the world, and including in in Botswana. And they set up this clinic, and people were afraid to go there, so they didn't label it an HIV clinic or anything. It kind of spread by word of mouth, but people called it the clinic with the white door. And they said, if you walk through the white door, your child will survive. If you don't walk through the white door, your child will die. And people knew that people living with HIV knew that they needed to get their children into this clinic to give them the best chance at survival. At the time, Botswana was one of the highest burden countries with HIV. I think around 30% of adults were living with HIV at that time. So an absolute crisis. And this small clinic started literally saving lives of children who are enrolled in care. They eventually built an established structure that's still up and running today and has served thousands of children, many of whom are now teenagers and young adults. And now moving to Malawi. Malawi is one of the other sites where we have the pediatric HIV program. But through our partnership with partners on the ground in Malawi, we've also been able to expand programming to so many other areas to improve the health of children, families, and communities. So over 20 years, Texas Children's has built essentially the largest treatment network for children and adolescents living with HIV. We've had around 30,000 children in care. And, having worked as a pediatrician in that setting in Uganda, I can tell you that most of these children are thriving. And with just some basic interventions like access to antiretroviral therapy, monitoring their labs, and providing psychosocial services, nutrition services, we've been able to make an incredible impact. So I want to take us back to the story of this young boy in Lesotho who came to us so sick and malnourished with a new HIV diagnosis. With care and treatment, we were able to restore his health, and he was able to then lead a healthy and fulfilled childhood. But this is, I think, my favorite photo in the series is this is now the same boy now, and he's 21 years old. He's thrived through childhood and adolescence, is now a young adult who's studying social work, and he wants to be a social worker in the HIV clinic in Lesotho. So I think this is just a remarkable series of photos. I mean, I get goosebumps every time I look at it and think about it. And this is just one boy. And if you think about the impact that we've had, thousands of times over on thousands of lives who've been able to follow this same sort of trajectory. It really gives me a great sense of pride and privilege to be involved in this work. But another part of our why, I highlighted the risk of transmission from mothers to children and our efforts to prevent that transmission. But we have actually achieved, just as of last month, the country of Botswana, which is one of the highest burden HIV countries in the world, has achieved the milestone of virtual elimination of mother to child HIV transmission. And so this means that future generations of children, will not be born with HIV, which is fantastic. And this was a tremendous achievement that earned recognition from the World Health Organization. Botswana is the first and the only high burden HIV country who has achieved this designation. And it's, through the work of the HIV programming, of which BPI and Texas Children's Global Health has been one of the largest players in Botswana. We're the largest center that's seeing pregnant women and children born to HIV positive mothers in our clinic. And so, this is just, it brings me so much happiness to see the children enrolled in our care who are living with HIV and thriving. But it brings me even more joy to know that future generations, won't have to grow up with it. So I want to just share some ways that you might be able to get involved before we open it up to questions. So first of all, we have a summer internship at Texas Children's for graduate students who are interested in global health. And this would be a position that's in our Houston offices, though it may be mostly remote, so may not need to be in Houston, to really learn about the administrative side and communications pieces of running a global health program. So these do not need to be health professional students, but any type of graduate student is welcome to apply who's interested in learning about global health. They would have an opportunity to work with our team over the summer. It is a paid internship. So if you have any connections with graduate students who may be interested, please send them our way. We would love to work with them. Another way that you can get involved is through donations. So I put a link and a QR code to our donation page. So it will take you to our website, which tells more about our work. And there's a donate button here, and you can select BPI, which is the Baylor International Pediatric AIDS Initiative, to ensure that the donation goes towards our pediatric HIV program. And then also to stay involved and keep in touch, you can feel free to get in touch with me if you have questions. And then our social media handles are the same across all platforms. We're on Twitter, Facebook, and Instagram at TCH Global Health. And we put lots of updates there and would love to interact with you in the social media spaces. So that is actually the end of my formal talk. I'll just conclude with this African proverb: if you want to go fast, go alone. If you want to go far, go together. And I think this reflects, the work that we do with our colleagues in Africa. Obviously, we are a small organization at the headquarters level here in Houston, and most of the work, tremendous work, is done by our colleagues who are on the ground in Africa. And under their tremendous leadership, we've realized such great successes. So with that, I think I'm going to end the slideshow and we can open it up to questions. I think you can feel free to either unmute yourself and just ask a question or put it in the chat.
Okay, I'll start. Good morning. My name is Raven Hollis, and I'm a senior biology major at Prairie A&M University. And the question I had for you was, how do you take care of your mental health with a job like this? I'm sure you get invested, in patients and things like that. So how do you keep stay balanced and afloat with your mental health? And what would you give tips for us to do as well?
Yeah, Raven, thank you so much. That's a wonderful question, and I think it is really important. For me, it's hanging on to the successes and remembering what a big impact that we're making. But it is, definitely some of the sickest kids that I've seen and taken care of over my career as a pediatrician have been children that I've taken care of in Uganda and children living with HIV, and definitely experienced losses of children too, which is it's always a tragedy when a child dies. And so I think for me, it's really hanging on to the successes. It's been, it's now been several years since I've worked full time in the clinic in Uganda. I was last working there in 2016, but I'm actually still in touch with some of my former patients there, and they email me updates on their life and how they're doing, and that just brings me a lot of joy too. But I think the other thing is, if you're going to do global health work, is just having other people who do that type of work that kind of understand the types of trauma that you might see in that setting and the high mortality that you might see, and being able to debrief and share with colleagues.
Yes, ma'am. Thank you so much.
Any other questions?
Hi, good morning. My name is Taylor. Oh, I'm sorry. My name is Taylor Bailey. And I just wanted to know, I know you have your internship for your graduate students. Do y'all have any other opportunities, like for people who may not be in school anymore, to kind of get a hands-on thing that y'all do as well, as far as like traveling and aside from donating?
Yeah, definitely feel free to send me an email and we can talk offline. I think the internship is like the current kind of well-defined opportunity that we have right now, but we may be able to think of something. And from time to time, we have kind of hands-on volunteer efforts where we might be preparing, a shipment or something to go to our sites in Africa and help packing it up or something like that. Or, depending on what your interests are or skills, we may be able to find something. So feel free to shoot me an email.
Yes, ma'am. Thank you.
Sorry, my question is more on, is it just physicians that are in global health, or are there other disciplines that help out with global health?
Yeah, that's a great question. So global health is a team sport, and we need pretty much every discipline. A lot of the work that we do for our global health network is actually not medical. Some of it is facilities and IT work to strengthen, make sure that our clinic building infrastructure is well maintained, and all the IT that it takes to support this network. And we've got an electronic medical record that needs to be built, and we've got statisticians and data officers who look at the data. We've got social workers, nutritionists, pharmacists. We've got people who are on the financial side and human resources side. So it's really a big operation. We've got a small and lean team here at the headquarters in Houston, but each of the foundations might have anywhere from 100 to 500 staff each to help run the whole thing. So it's very interdisciplinary work. Any other questions?
I have one more question, just in case.
Sure.
So here in the States is children with AIDS, it's how are we progressing with that? Is it almost extinct or?
Yeah, that's a really good question. It is almost extinct. So we've done pretty good work with HIV prevention, first of all, in the US. And, so we have a lower number of pregnant women who are living with HIV to begin with. And then, here most women who have HIV are detected before pregnancy or during pregnancy and able to start treatment right away. And so we have virtually eliminated the transmission of HIV in the United States. I think there's something like maybe 100 to 200 babies born HIV positive per year in the US. So it's a very, very low numbers. And so we do have a pediatric HIV clinic through Baylor College of Medicine and Texas Children's. But, since there's so few babies being born, most of those kids have actually grown up and aged into teenagers or young adults now. We do see also pediatric HIV transmission in the US through sexual intercourse in teenagers, but we've got in general very low numbers.
I know I was another question I had was that I saw on the website that you had teen camps. How is that addressed at the teen camp?
Yeah, thank you for that question. So all of our sites in Africa have camps for the children living with HIV. And they're week-long camps that you have to be nominated to go. And so counselors at the clinics will nominate kids and teens who they think would benefit the most from it. But it's basically coming together in a setting where everyone is a child or adolescent living with HIV. So you're not, the odd one out. You're amongst other people who are going through the same struggles. And it's really about learning positive living and how to live positively with HIV and address internalized self-stigma, how to deal with stigma in the society, how to be advocates for other children. And then they just do fun things like fashion shows and games and races and let kids be kids in that setting. So I think we had to pause them in 2020 due to the pandemic, but they've been able to get them up and running in different forms to keep kids safe from that perspective. But it's been a very powerful part of the programming.
I have a question. Do you partnership with the middle schools and high schools in regarding HIV and AIDS and the stigmatism and the transmission of it?
Yeah, so that's a great question. And we have done school partnerships. I think a few things. One is that the children who are living with HIV, they have to take a daily medication. And a lot of kids in those settings go to boarding school. And so there's a lot of stigma around HIV and, but they have to take this medication that, sometimes multiple doses a day. And so in some cases, we've had kids become non-adherent to treatment and stop taking their medication. But when you really talk to them, it's just because, it's so hard to take this medication discreetly at school and to not be stigmatized for it. So forming partnerships with the school nurses and empowering the kids to, you know, figure out a way that they can take the medication. A lot of them end up saying they have something else like sickle cell disease or something else that's chronic but not as highly stigmatized, and that's why they take the medication. Um, but we also do HIV prevention programming in schools in partnership with schools to talk about safe sex and sexual and reproductive health. Um, but there's just so much stigma still, decades later. It's still a highly stigmatized disease. And so I think also just work to destigmatize HIV in the school setting. In the earlier days, and I think some of this still persists, there was, concern that I don't want my kid going to school with a kid with HIV because they share a cup, or if they're sitting next to each other, are they going to catch HIV? So I think also just education around, those are not ways that HIV can be transmitted, and it is safe for your child to attend school with a child who's living with HIV. But certainly schools are a really important place for intervention. I see one question, a couple of questions in the chat. Do you deal with social emotional activities? That is a great question, and it's a huge part of what we do. So all these kids come to clinic on every 3 months to every 6 months. And that's just to receive their refills, check their growth. Sometimes they need lab work while they're on antiretroviral therapy. And during each of those visits, they also meet with one of the HIV counselors. And that is a huge part of their visit. And it's really working with them on accepting their diagnosis and accepting their chronic disease. A lot of the kids who are teenagers moving into young adults, it's working with them on becoming independent in managing their chronic disease as young adults, because they're not children anymore, and they may not have a parent who is supervising them taking every dose of medication. A lot of these children are, now adolescents, young adults who are coming to terms with their own sexuality, thinking about starting families of their own, and having to navigate all of that while being HIV positive. It's just a lot. And so I think even as a physician, I spend a lot of time doing more of the psychosocial part, especially with my adolescent patients. They just have so much. Like I said, the self-stigma is a big piece of it too. And then, these clinics are all in low and middle income countries where the baseline rate of poverty is also so high. And so, some of them are living in poverty, absolute poverty. So we also have classes to teach them income generating activities like making crafts and how to open a savings account and basic budgeting and those types of life skills as well. I see Olivia has her hand up. Yes.
Hi, good morning. I'm Olivia Lemon, and I currently work as a family and community engagement specialist at a high school right now. And I was wondering, what are some good HIV prevention tips that you could give me to pass on to them?
Yeah, so I think, that's a really important question. I think for adolescents, for HIV prevention, most of it is going to be around, abstinence until you're ready, safe sex, using condoms, knowing your status. I think 2 tools that everybody should know about so that you can advise, a young person or adult who's coming to you is that we do have both pre-exposure prophylaxis, which is called PrEP, and also post-exposure prophylaxis, or PEP. And so for young people who are engaging in high-risk sexual activity on a regular basis, it may be that they could get started on a PrEP, which is like a preventative therapy that you take to prevent HIV. And so sometimes we recommend that for like really at-risk youth who are engaging in really high-risk sexual activities. And then if somebody comes to you that, they had a consensual or non-consensual sexual encounter that was unprotected, you should be able to tell them that post-exposure prophylaxis is an option. And then if they don't know that person's HIV status, or if it was a non-consensual assault type of situation, that those drugs are available to help prevent HIV after the fact. And so just knowing that that exists and being able to refer them to that, I think is also really important. But really that's sexual transmission as the main mode of HIV transmission in the US. In some other countries, they still have outbreaks from blood transfusions, but here we've got really good screening programs for our blood transfusions. So yeah, thank you for looking out for our youth. I see a couple other questions in the chat. Aside from medication, what other treatment do the children undergo, such as therapist classes, etc.? Yeah, that's great. So like I said, they do a lot of meetings with the counselors. We have a nutrition program. We need to optimize their nutrition too. If they're malnourished, sometimes due to food insecurity and poverty, then the medications won't work as well to prevent HIV. I think also if they're not, for all sorts of reasons, these kids kind of fall off the boat and maybe stop taking their medication or aren't taking it every day, and really working with them, sometimes doing home visits to really assess the situation at home and understand what is happening here that these kids aren't able to take their medication every day. Sometimes, I've even seen situations where maybe mom knows about the child's HIV status, but she has never told the child's dad. And it's been hidden, and obviously that's an adherence barrier. If somebody in the family, a caregiver, doesn't even know about the HIV status. So we do encourage disclosure to other family members if it's safe to do so and can help with that disclosure process. So that's a lot of the work, big role for social work and counselors in that setting. And then classes, yeah, like I mentioned, the life skills training and nutrition classes. We have Teen Club, which is a Saturday session run just for teenagers, where we have kind of experienced patients who've been on antiretroviral therapy for a long time, talk to and mentor other teens who are struggling. We've got a Teen Mom Club, where we bring in mothers living with HIV who are teenagers, and they can come with their babies for psychosocial support. So it's really holistic care. There's so many different aspects. We also have a play therapist at all of our sites, and they'll read books and play with the children as they're waiting for their appointments. And then somebody's asking, what's the greatest need that we can support to help further the work and the mission of the program? I think that's a great question. Some of it is really awareness. And so, I think it does help us to follow our social media and share those stories. I think right now, one of the things that the programs, one of the biggest challenges obviously is COVID. So, we've got tens of thousands of children who need access to a daily medication without which they could die. And suddenly all sorts of challenges thrown in the way because of COVID. And each of these countries had different types of lockdowns. They've had different surges. Some of our sites in Africa, their vaccination coverage rate is less than 3% of the population has been vaccinated against COVID. And so they're still highly susceptible to COVID infection. So all sorts of challenges that we're navigating around COVID. But I think definitely keep in touch with us, and as we have needs, we put them out through our social media. And then someone's just commenting, extremely important, especially with peer pressure with high school and even college students. Yeah, I think that's a really, really important point for our family engagement colleague, is just teaching kids how to stand up to peer pressure. And I think also teaching everybody what consent looks like, and that no means no. And I think there's a lot of room for improvement in the quality of our sexual and reproductive health education for our teenagers and young adults, so that they're fully empowered to go out in this world. Okay, well, these are all great questions.
Okay, it's coming close to our closing time. We have a time for one more question. If there's one, someone would like to ask Dr. Hawk. If not, I turn it over. I'd like to introduce our second Vice President, Dr. Donald Powell.
Good morning, and on behalf of the Prairie View Alumni chapter of Delta Sigma Theta, I would like to thank Dr. Hawk for taking time out and providing us with her expertise and her professionalism and bringing us up to date on AIDS awareness with our youth, which is it's a huge area that we definitely need to be aware of that might have been forgotten. But thank you for your time, and we definitely look forward to speaking with you and working together with you further. I'd like to thank our guests and our sorors for joining in this morning. Thank you so much for taking time today. So thank you all, and stay safe, and we'll be meeting again soon. Thank you.
My pleasure. Thank you all so much. Bye-bye.